Welcome back, everybody, to Pivot Point of View. I'm Destry Millsap, and Becky couldn't be with us this evening, but we do have a very special guest, one of my good friends and colleagues, Dr. Ian Goodman. He's our team doc here at Owasso with Tulsa Bone and Joint. And tonight we're going to be talking about hip labrums, management, surgical techniques, rehab, all of those things. If you missed our past episodes, go back and watch them. We had some great ones with the Pro 6 people, Deb Christie, the Gaffneys. You don't want to miss them. Go back and watch them. But we're very excited to have Dr. Ian Goodman on here and honored. Dr. Goodman, welcome to the show.
Oh, thank you guys. I appreciate it. This is an honor. Uh, Definitely heard a lot about your podcast and proud to be here. Thanks for the invite and always wonderful working with you.
Yes, sir. I mean, ever since you came to Owasso, everything has just been so great. You're such a knowledgeable and great doctor to the point where you fixed my own knee. I mean, and I haven't had a problem since. I tore both meniscus in my knee a couple years ago. And Dr. Goodman gave me the best care possible. My knee has been great. It was kind of like an 80% deal. Like it was a deal where, you don't do it right, it's probably not going to heal correctly. And I haven't had a problem one thanks to you. So, but we're talking about something else tonight. And first, I just want you to tell us, where you came from. You were a college athlete. You've been in the military as an orthopedic surgeon. Tell us about all that.
Yeah, grew up in Arkansas, River Valley, kind of Russellville, Arkansas area. So if you drive down I-40 between Little Rock and Fort Smith, you see the big giant nuclear reactors. That's home for me. This is home now. We got to settle down here. So grew up there, went to medical school in Arkansas, in Little Rock. But prior to that, went to Creighton University and then Central Arkansas for playing soccer. I was a goalkeeper. So don't judge me on the soccer side. I was actually, a goalkeeper and enjoyed being a little bit more physical. But, you know, after that, after college was med school. After med school, and during that time, commissioned into the Air Force, did our training for residency in orthopedic surgery down with the Air Force down in San Antonio, Wilford Hall Air Force Hospital, and then also with Brooke Army Medical Center. After that, we got sent to Destin, Florida with Eglin Air Force Base and spent 4 years there. A little bit of that time was in the sandbox, 6 months in Afghanistan, and finished up that time in service after 9 years. Went to our fellowship at University of Kansas for sports medicine, and then the good Lord brought us here. So we're happy to call Owasso home, and I've got a wonderful wife who's a physical therapist and two daughters. So being a girl dad is probably the most challenging thing I'll ever have to do.
I imagine it is. I imagine it is. And you and your family are such great people. And I got to meet your dad on the sideline, ER doc. I mean, you come from good stock there. So even though you're Razorback, we're glad to have you. And 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 you've done great with our athletes. And speaking of our athletes, we have had what seems like an uptick in hip labrum issues. So talk about kind of your thoughts on maybe what you've been seeing trends wise with the hip labrums and kind of the signs and symptoms you look for to differentiate from other injuries to the hip.
Sure. I think, first, the increase in labral injuries as well as just femoral acetabular impingement, or FAI is what we'll call it, impingement of the hip. A lot of that probably is more, some of it's just the fact of diagnostics, right? We're a lot more aware of it. We work it up a lot more. And we've gotten some of these things that now cue us to say, this is probably more coming from the hip than necessarily the low back or other areas. The hardest part with the hip is you've got a lot of areas of compensation. And so back pain can cause hip pain can cause back pain. And that's probably one of the biggest differentiating things you got to get is which. I think first and foremost on those two is, do they have any shooting pain down their legs? Do they have any signs of what's called radicular pain? Does it hurt them to do a straight leg raise? Does it hurt them to bend over into a flex position? Or with our young athletes, does it hurt them to hyperextend at the back, right? And then you're getting into some different low back pathology. The hip itself, I think what we're seeing more and more, and you hear it from the athletes a lot more than I do as far as their specific complaints. So correct me if I'm wrong, but a lot of it's more of a some of them are having pain with running, some of them are having pain with jumping, but a lot of them it's just a daily discomfort of I'm trying to sit in class and I can't sit in this position upright for any extended period of time. I feel like I have to kind of lean off to the side. I feel like I have to get up and walk around. And even then, walking or standing for a prolonged period, that becomes a symptom too. That's something that else causes pain. And part of that cycle is those compensatory effects of the hip. When the labrum is torn and from the impingement, you start getting a lot of hip flexor tendonitis. You start getting a lot of adductor tendonitis right there on the inner groin. And so I think some of these people go through a lot of time being worked up for groin injuries, right? And eventually it kind of turns its ugly head to that point right in the front of the hip where we're talking about a C sign where people will kind of put their hand around their hip and their index finger will end up going right over that kind of groin crease. And that's where the hip joint actually sits. And that's, if you're feeling where that's where that pain is, then that's a pretty good indicator that it's either your hip flexor or it's your joint. Um, those are some of the first things. We get a lot of bursitis or irritation on the outside part of the hip. That doesn't present as much in our high school athletes and our younger athletes and our collegiate athletes and professional athletes. I think more because they have good functional strength. I think they actually start getting more in that population, more SI joint issues and glute kind of pain with it. But I think the biggest presenting symptom is really that groin pain right in the front. Uh, to the point of when I hear somebody come in with predominantly posterior hip pain, I'm starting to kind of have my differential go in a different direction and think that it's got to really convince me that this is hip impingement and labral pathology in order to go there.
Absolutely. And just for context, on this show we cover a lot about horseback riders and kind of the Western lifestyle and how those things all affect each other. And so, like you said, the hips affect the back affects the hips, and those are two main problems that people that ride a lot have. And so, figuring out is
Mhm.
it the chicken or the egg and all that stuff is so important, and having a good doctor like you to get that correct diagnosis is absolutely imperative. So, whenever a person is diagnosed with a hip labrum tear, usually through an MRI. Um, what are some of the management options for these labral tears? Because we know that the labrum tear in the hip is a fairly common deal. A lot of people have them. They may be asymptomatic and then they're not. So, what are some of the management
Sure.
options there for labral tears?
Yeah, I think the hardest part that you and I deal with, and a lot of people are going to deal with as patients, is we have to really emphasize a non-operative medicine approach. And non-operative approaches should happen first before anything surgically, anyways. You can't take back something surgical, right? So as much as I'm a surgeon, I'm a physician first, and so you got to treat somebody as a physician and treat them as though our goal is to keep them off the operating table first. I think first things first, it's they have probably some impingement with it, right? Now, that's not always the case. There's some labral tears that come from people with hypermobility, where they've got really loose joints and they actually have this kind of what we call micro instability of their hip, and they've got a labral tear as well. And the biggest thing is with all of those, it's still saying we've got to really focus on glute strength. We've got to really focus on core strength. We've got to focus on postural adjustment, on how do we sit properly. And the hardest part is for your population, for the people that are spending a lot of time on horseback. Probably the best thing is to not be on the horseback for a period of time, whether that's 2 weeks or 4 weeks. And that's hard. It's really difficult. But I think that's step one is the physical therapy with regular anti-inflammatories. I think a lot of us are afraid of taking anti-inflammatories for a long time. This misnomer that's come through the world of it's going to cause your kidneys to be going to failure. Taken inappropriately, yes. If you're doing what some of us did in high school with chewing down some ibuprofen just to get through the next game, which was really dumb, I was one of them. But that's not good for your kidneys, and that's not good for your stomach. And So taking it appropriately, where we're talking three ibuprofen 3 times a day or two Aleve twice a day. That's a really good over-the-counter regimen of non-steroidal anti-inflammatories, which helps with that inflammation of, especially those other structures we talked about, your hip flexor, your outside part of your hip, your troch bursa, and the bursitis that comes from that. All those tendon issues that get irritated, it helps. And the biggest thing is when you think, why does the hip flexor get so involved? You got a ball, you got a socket, and then around that socket is that labrum. But just over the top of that is this hip flexor that runs right over the top. So if you got inflammation in here, it's going to affect that hip flexor, causing inflammation too. And so get the inflammation down, get the strength back, get the alignment back. Plus or minus doing an injection with a steroid. I use an ultrasound in clinic. Some guys use X-ray guidance and they put some fluoro medicine down in the hip to verify that they're there. But getting an injection in there. If I have people with just hip flexor tendonitis and that's not resolving, I actually send them to one of my partners and he'll inject the tendon for them. Does that under ultrasound. But I think non-operative is the goal, and for two reasons. Nobody wants to be cut on. That's the goal there. It takes a long time to recover. But the second reason is insurance. Almost all insurances mandate that with hip impingement, hip labral tears, no matter what it is, even if it's traumatic in nature, it's very difficult to get them to authorize surgery without doing 3 months of activity modification, changing what you're doing with physical therapy plugged in during that course of time.
I completely agree. And I think, in the past, a lot of the times the hip flexor strain, groin strain, um, some of that stuff, maybe we thought it was that tendon and only that tendon when really there was a labral tear underneath of that. And like you said, the increased awareness and the stuff and the diagnostic things. Now we're starting to find out it's actually a labral issue. But this is why I respect you so much as a surgeon is you are physical therapy first, if possible, if that's a reasonable option. And that's why I respect you so much, is you're not going to cut on something that you don't think absolutely has to be cut on to be fixed. And so I think that's an important thing that people need to realize too. And then also using the anti-inflammatories and an injection, injections are good too, just so we can get you in a reasonable amount of comfort so that we can perform effective physical therapy to get you better, and I think those definitely go a long way there. And as people go throughout their rodeo season and stuff, it's hard to get them to stop or take any time off. So these other methods of PT and injections and stuff in the appropriate manner to get them through the season definitely is a good way to go about it sometimes. So, what about
Yeah.
say that physical therapy didn't do what it was supposed to. Maybe the injections aren't lasting as long as they're supposed to, and or it's just a really bad tear, and we're looking at potential deterioration of the joint if we don't fix this. Talk about when it is time to go to surgery and what techniques you like to use there.
Yeah, I mean, you know, the biggest thing that you've said and I've said, both of us, is the trigger word for our population, for Americans, and most people, tear. That TEAR word. It's naughty, it's awful. It's one of those things. It's like, I have a tear, I need to fix it. So again, first thing, let's make sure we try to avoid having to fix it and let your body try to heal it. Let your body try to make up for it. Most people believe the labrum's part of that pain, but really the impingement's the bigger part of it. And it's when that impingement's become the driving force of that discomfort of it hitting into that spot, that's where you get your discomfort. And so, you know, the hard part to believe is that impingement's causing the pain for everybody, especially when you look at the NFL combine and 80 to 85% of athletes every year have hip impingement on their x-rays. And of those people, only about 2% probably have an actual labral tear that needs to be taken care of. And so it's a difficult thing to say, you have impingement, so we've got to take care of this. But if you're going to have to take care of the labral tear, you have to address the impingement at the same time. And that's the biggest thing to do. So the ways we have to do that, getting back to your question, Um, Surgically is really either arthroscopic or open. And open, I think, is a long gone, predominantly antiquated kind of surgery at this point in time over the last 15 years. Hip arthroscopy has become something that was almost unheard of until 15 to 20 years ago. Now it's something that the whole reason why I did my fellowship at University of Kansas was really to get hip arthroscopy exposure and to be comfortable with it. I felt like I had a lot of exposure in other stuff, and I needed that. And so, but trying to avoid the open surgery because ultimately they have to dislocate your hip when they do that. That's extremely painful. There's a lot of risk of other structures dying when they do that. So with hip arthroscopy, we can put you on a table, we put you to sleep, and we're doing two, three, four stab incisions around your hip. Most of my work can be done through two stab incisions. And we're talking the size of your fingernails as far as the width goes, you know. And you're taking that scope, you're going down through into the hip joint with a little bit of separation of the joint, kind of about, that much, so that by pulling what we call traction just against it, right? Everybody knows traction. We're pulling it on when the horses are pulling your sled, they're pulling traction, right? And so anything is really, we're just distracting that joint a little bit so we can get in there, not damage the cartilage, and then identify the tear. Uh, at that point in time, once you've got the tear identified, I typically open the capsule up. So basically from one portal to the other. And then I plan on repairing it at the end of the case. But get the tear identified, fix it up, get a good bleeding surface of bone, and then you put some anchors with some suture into those. All the anchors that I use are either dissolvable in the bone over time. We're talking probably years, or they're just an all suture based anchor that kind of goes in and acts like a sheetrock anchor. So it goes in and then flares out. And those help just pull that labrum back to where it belongs and make it become more of a round substructure. And the goal of it is that the socket going around the ball now, instead of having this loose part right here, it actually seals in again. So you get this suction phenomenon that the hip should have. And once that's there, you've really kind of attained the goal of the labral repair. Now you want to attain preventing that labral tear from happening again. And so shaving down that bump that's on the femur that sits kind of right in this area that would hit, that's the impingement spot. Most people, the impingement spot's on their hip, on their femur side, their thigh bone. Some people, it's on the socket side. Some people, it's both. And so you want to shave down whichever side that impingement's coming from. And I use a computer system in the operating room that plugs into my X-ray device. And I kind of take the hip through six different points of rotation to see where those impingement sites are, get my measurements ahead of time, and then shave it down to get them all into a position that's less than impingement. And then you just check them again at the end of the case, make sure it's not impinging. So after that, close the capsule. And then the hardest part of the recovery actually starts at that point in time. I think the surgery's easier for a lot of people than the physical therapy and recovery after that.
Right, right. And I love what you said there. And again, it's why I respect you so much as a surgeon is if you don't fix the reason that it happened in the first place, you're probably gonna have it happen again. And so fixing that impingement and whatever other pathology made this happen, whether it was, like the bumps on the femur or whatever, if you don't fix what was happening biomechanically, then you're going to be at risk to do it again, and maybe on the other side even.
Mhm.
So, um, you know, again, just love how you think there, and that's why I respect you so much as a surgeon, because I'll respect somebody who is going to exhaust every option before they cut on me than somebody who's really got their knife and is eager to sink their teeth into it. So, I sure appreciate that. What do people typically look like on the operative side? If you have a hip labrum surgery, how long are we looking before we get to ride again? And how long is a full recovery?
Yeah, most people, I think you're back riding about 3 months post-op. We've got a really, unfortunately, that jarring effect of being on the horse is a pretty nasty kind of motion for the hip. And so I will let some people get on and start kind of getting into a walk and a slow trot with their horse at about 8 weeks. But really riding at 3 months. And during that time, you're being careful. You're swinging your non-operative leg over first, so that you're not getting your hip into a position that's putting it at risk of tearing that capsule that we closed and all that stuff. Um, the full recovery, 4.5 up to 6 months. And I think, uh, distance runners are the ones that take the longest. So people that do more of an endurance related sport, if you're doing a lot more time on the horse with whatever sport you're doing, and we're talking equivalent of 30, 40 minutes, 60 minutes kind of thing. That's an endurance time for your hip and your glutes and your inner thighs. That may take you longer than somebody that's more of a fast twitch athlete. And so 4.5 to 6 months on average. But you're on, as long as we repair the labrum and we don't have to do what's called a reconstruction, then crutches for 3 weeks, putting half of your body weight through your leg. Over the course of the next week, you're getting to where you're walking on your own. And I always warn people that week 4 through 8 is kind of the hardest time, because prior to that, they felt good. Their pain was getting controlled. It was really good. Now we're back to walking, and we haven't really done much to address the deficits that led to that tear and that led to that pain. From the dynamic side of the hip, we haven't addressed the glute strength. We haven't addressed the core strength. We haven't addressed hip flexors and the inner thigh, the adductors. And so that's the stuff that, because those are still weak, you're going to hurt when you start to walk again. And so I always tell people, I warn them before surgery, I warn them at 2 weeks up post op. I say, don't beat yourself up. You're going to also not love me at this time when this happens. Just know and be prepared for it. And if you're that 30 to 40% that it doesn't happen to, congratulations. But it's a road, it's a journey. Typically running at 3 months as well. That's the other, riding, running, 3 months going together. But it's really making sure that you've got your full functional strength back before whatever we're doing. If we're roping, uh, we got to be able to get off that horse pretty quick, right? And into a compromised position pretty fast. And so it's definitely something that you want to make sure you're healed and you're strong and you're capable before you go back full speed ahead.
Absolutely, and it's all a progression, and you can rely on your physical therapist and your doctor to help you with that progression. Is you get on your horse again, and it's not like you're gonna go full speed, 100% down the arena. I mean, 3 months we're getting on our horse, walking, trotting, maybe working up to loping circles there, and by the end of week 2 or something, and then starting to do functional drilling and things like that. Week 3, week 4, like
Mhm.
roping the dummy, chasing the sled for the ropers, and maybe just break away in some slow cattle there at the end of the third or fourth week. But really, just get back on your horse, getting them back in shape, getting yourself back in riding shape. Those first 2 weeks is absolutely critical, and then working back into functional stuff that's more combined with those other two movements, in a controlled setting. You don't want to go get on your 3-year-old colt probably and go to roping the sled where you may not know which way he's going to go unless you just got an absolute lazy bedhead like some of us are blessed to have. But go get on that old rope horse that you know what he's going to do every time, and he's not going to take a bad step. Go rope the sled, get comfortable doing that, make sure that we're ready for the next step, and then, you know, maybe you start roping some slow cattle out of the box and then progress on from there and get into those high runners, and even if you're like a calf roper or steer tripper or something like that, just going trotting, loping around the arena, um, and working on your timing, and then eventually whenever you're cleared, doing get offs and stuff in a controlled state rather than full high speed, because I mean no one knows what's going to happen, and then you put yourself at risk of injuring something else if you're not ready for it. So
Mhm.
um,
Yeah, I think your point's exactly right. I think the last thing you want to do is say, I feel strong, I feel capable, I feel able, uh, but the rest of your body hasn't done this. And so suddenly you go from I had a hip injury to now I've got a low back injury, I've got a disc herniation, or even worse, I have a nasty fall and I separate my AC joint or I tear my ACL, things that are going to be just as long, if not longer, on a recovery. And it's that much bigger of a setback. And so the hardest thing for everybody to get, I think, is that, you know, hardest thing for you in the athletic training room with high school athletes, it's that return to run program, right? Is try to build up slow, but don't be a knucklehead. Don't be an idiot. And just go slow. You're a tortoise, you're not a hare. Let's build into it so that when the time is right, you can be that hare again.
Yes, sir. Yes, sir. And you know, you went through all that work. You definitely don't want to screw it up for nothing and then
That's
set
right.
yourself. Absolutely not. So, anything else you would like to add about hip recovery, hip techniques, impingement, anything like that?
I think that the other thing that I see a lot out of the riding community, especially, um, it's more common in ladies than it is in men for whatever reason. But when they start getting into our young 50s and our 60s and they're still riding, I think that repetitive trauma on the lateral aspect of the hip on the saddle, um, I've seen a whole lot more glute tendon tears on the hip in that population. And so these people that have that chronic kind of outside of the hip pain, and it hurts them to walk and they can't go long distances, and especially hurts them to go up like inclines and stuff. And then they can't ride for as long. They can't sleep on that side of their hip. Those are things I think that, especially in your population, that I've seen a lot of with these glute tendon tears. And it's ones that, instead of going and seeing your primary care doctor and getting over and over again injections, if you've had more than two injections on that outside part of your hip, I think you need to get an MRI and you need to know what those glute tendons look like. You need to see if they're torn. And at that point in time, what's the degree of tear that they have? Is it very low grade? Is it high grade? Is it complete? And that drives the boat of does that need to be surgically repaired as well? Excuse me. But I think that that's something that a lot of people think my hip is that outside part of your hip. And if you're hurting there and it's just not getting better, it's something you want to look into. But that population specifically, I know a lot of, and they're not necessarily our rodeo athletes anymore. Some of them are, right? But they're people that were, and they're still doing life like they were when they were younger, and then they're hurting. And so that's a big part. I think otherwise, less common for most people on horseback or rodeo, but there is a core muscle injury. The old sports hernia that we hear people talk about, and that's going to be more pain right there, kind of in the middle of your body, right over your pubic bone, and then that adductor tendon that we talked about earlier. That's where the majority of your pain's coming from, and that's something that if you're just not getting better and it's not coming from your hip, it actually hurts more to do a crunch. It hurts more to kind of come across your body and be pushed back in that position with a crunch. Running and kind of coming up into a vertical position, those things, that's that core muscle injury. And that's something you want to get addressed as well.
Let's go back to that glute tendon injury you're talking about because I have seen that with a few of my clients before, and have treated them for that. It almost sometimes can present like, a hip bursitis or something like that on the outside. But tell me what kind of mechanism you think may be causing that.
Uh, if we had a perfect answer, it would be great. But I think it's to me the glute tendons of the hip and that troch bursitis. It's very much like the rotator cuff of the shoulder and subacromial bursitis as well. Sometimes you have a traumatic incident that fall directly onto the outside part of the hip, or you were trying to catch yourself from hitting your butt, on the pavement and catch yourself in a deep squat, and you can feel something pull on that side of your hip. That's the traumatic side. Otherwise, it's really more of a chronic, age-related. I tell people candles on the birthday cake, right? As those get a little bit more, then ultimately some of our tendons start to wear out. And I think the biggest thing is sometimes that bursitis is not just bursitis, it's bursitis because the structure underneath it is torn, and it's the glute tendons that are torn. And so that's why, to me, really two injections, if you've had two injections, get an MRI after that, because I've seen countless patients that come into me and they've had 10, 20 injections over the course of several years. And now you get an MRI and that tendon's blown. That tendon's so torn, very much pulled back. And you really, it's going to be a hard discussion of whether it's even repairable at that point in time. And so now you've got those people that when they walk with their hip kind of thrusting out to the side on the other hip the whole time because they shift away from that hip. And so they get this little lurch in their pattern that goes over, and it's constantly hurting, and it hurts to lay on that side. It hurts to sit for long periods on that side. And that's something to be very aware of because just like the rotator cuff on the shoulder, if that's not functioning properly, you're going to have a hard time of getting other structures around your hip to function properly.
Yeah, I agree. And the longer you go on with that, the more structures, other structures are going to be affected, compensating up and down the chain, and it'll make riding absolutely miserable. And that's where the functional evals for me are so useful is identifying those areas with deficits and being able to attack those that help address some of these issues that are causing these chronic issues. So like, what do you like to see physical therapy wise, and what activities should a person avoid if they think that they have a glute tendon injury, and what things do you think would help them with this glute tendon injury?
I think that the therapy is really pretty similar between just pure hip impingement as well as glute tendon. You're doing a lot of planks. You're doing a lot of clamshells. I think resistance banded side like lunge walks and things like that is actually a really good resistance training for it. Um, I think you want to, as much as you can, try to avoid uh, the up and down. So if your butt's coming out of the saddle and then it's coming back down with as you're running your horse, that's probably if it's actively partially torn, you're probably going to be causing trauma to that the whole time. Because as you're coming back down, you're firing your glutes. And then as you're firing them, you're kind of getting almost that mechanism for the Achilles injury, right? You're in this eccentric contracted position, and then it hits something really hard and it wants to try to recoil back. And so, uh, you know, you can't change what people do for life. We all have things we have to do. We don't get a choice. I think the biggest thing is try to, just like everything else, it's try to rehab it, try to get the strength proper, both to your core. Let's be honest, most of us have really bad core strength. And then it's also glute strength and it's building up proper glute strength. And, I think getting an IT band stretch too. I think really focusing on hamstring flexibility, low back flexibility, IT band, just getting that thing kind of, you can do foam rolling, you can do lacrosse balls, uh, but then getting glute strength and getting that core strength. And I think core strength is so much more than crunches and the stuff that tears up our back. It's mostly planks and it's sideline planks and it's frontline planks and it's doing, the what is it, dead dog and bird dog positions where you're kind of going arm and leg. Yeah, bird dog. Sorry.
Little
Yeah,
dead bug, bird dogs, you betcha.
yeah,
Yeah,
doing all those and yeah,
yeah, absolutely. And this is where we go to talk about that hip internal rotation again, being able to have a solid seat by having the mobility with the hip rotation. So when you turn, your hips have that mobility to turn and they're not getting locked in your back or your hip labrum or even up in your T-spine, making sure that all that stuff is moving and working together as you go to turn independently of those hips on your horse and being able to cue your horse correctly by having proper mobility and having a solid seat in the saddle. That's definitely what the goal is as you look to take pressure off of those structures. So, all right. Well, sir, um, do you have anything else for us tonight?
I don't think so. I mean, nothing else I can think of. I'm not, not your hip expert. I do several hips, take care of a lot of hips, but I'm not by no means am I the hip expert. I got some guys I trained under that are definitely that, but definitely I appreciate just trying to share what I do know and what I've experienced. And those glute tears, if they are something that has to be fixed, there are some people that fix them open. There's some people that fix them through the scope. I prefer to fix them through the scope and a few stab incisions for that. If it's not torn all the way off and way out of the way, if it's torn and it's pulled way back, I typically open it up and fix it. But I try to fix most of them through the scope if we can.
Well, I know that our athletes that have had hip surgery with you have done great and very knowledgeable and very handy with your hands as far as that goes. And I also like that you're humble enough to be able to have a network of referrals for people when you see something, you're like, you know what, I think this person will be the best man for this, and having the network to refer that out and get them to somebody that you feel like maybe has more experience for that certain type of hip deal or whatever. I truly respect that too. So, awesome. Well, thank you, sir, for coming on here. Absolutely honored to have you on our podcast, and I'm sure we'll have you on here again to talk about your many talents with knees and shoulders and all of those things. You do such a great job, and we're very thankful for you at Owasso for sure. So, thank you again, and thank you all for listening. And I'll go ahead and close it out and let your health be the pivot point to your success.